So this slideshow is called Laboratory Evaluation in Endocrine Disorders. So it's a bit of a potpourri here. In fact, for many endocrine disorders, a lot of the evaluation is going to be done by specialists. Maybe gynecology for more GYN endocrine type issues, maybe urology for men's health issues, maybe endocrinology for certain issues. But you do need to be aware of all of these tests, and depending on your level of experience, you may actually start doing some of them. So the basics. So endocrine, the big endocrine thing we see, of course, is diabetes. So just to review, the glucose level, you need 2 glucose levels above 124 to make the initial diagnosis, 2 fasting glucose levels to make the initial diagnosis of diabetes, or alternatively now you can have an A1C above 6.5. Remembering that the finger stick is usually a little bit lower than the spun down blood sugar that's done in the lab, but they should not be dramatically different. They should be a little different, and so when they are a little different, that should be expected. And we'll talk about the hemoglobin A1C in a minute. That is a test which gives you an idea of the average blood sugar. The elderly, we think, may have a bit of impaired glucose tolerance. This should be minimal. That clinical significance is pretty modest. And to be honest with you, I usually don't even consider it in regards to taking care of people. Other diabetes tests. So if you've got somebody who is a new diabetic and you're trying to figure out whether or not they're a type 1 or a type 2 diabetic, there are some tests that you can do. The most common one that's done is the C-peptide. C-peptide is basically the thing that's split off from proinsulin when insulin is formed. So proinsulin splits into C-peptide and insulin. The insulin is used up by the patient. The C-peptide hangs around for a while, and if you have external insulin being given, obviously there will be no C-peptide there. So if you have someone who is a new diabetic, their blood sugars are high, if you do a C-peptide in a person who is a type 1 and is not producing insulin, their C-peptide is going to be very low. In a person who is a type 2 and is producing a lot of insulin but has a lot of insulin resistance, their C-peptide is going to be high. So it can be a very useful test, especially in the new diabetic. The hemoglobin A1C is a test that looks at a molecule on the hemoglobin, the A1C molecule, and in fact the sugar deposits on that molecule over the lifespan of the hemoglobin, which is about 90 days for the red blood cell. That means we get an average blood sugar for the 90 days, and we can actually compute that. The next slide will give you an idea of what those actually translate to be. Fructosamine is a test that you don't see done very often. It's supposed to be less interfered with by medications. It's supposed to have certain advantages. The biggest disadvantage is that it is a protein molecule that only lasts 2 or 3 weeks, so it actually gives you an average blood sugar over only 2 or 3 weeks. The biggest problem with the fructosamine, I find, is that it's often a long time before you get it back. The last time that I ordered it, it had to go to San Juan Capistrano, California to be run. It may be being done more locally now, but again, it's a hard test to get a good result on, and so most people just do the hemoglobin A1C. It'll be interesting to see if that practice changes over time. So this slide does give you those average A1C levels from the Mayo Clinic, and you can see that an average A1C of 6 is equivalent to an average blood sugar of 126. So again, once you get up around 14, that patient's going to be averaging over 300. 300 seems to be kind of a critical level because most patients do not have much, if any, symptoms until they reach 300. Once they reach 300, they'll actually start to feel drifty. They'll start to feel confused. A type 1 diabetic will have symptoms well below that, however, not because of the sugar, but because of the alternative metabolism that's occurred. So it is not the high blood sugar that actually gives a type 1 diabetic the symptoms, it's the high ketone levels that actually give them the symptoms. So in a type 2 diabetic who is still producing at least some insulin and therefore not really producing much for ketones, they will usually get much higher blood sugars. I've seen as high as 1,000, whereas a type 1 diabetic, by the time they get to 300 or so, they've got so many ketones in their body that they're acidotic and having major issues. Other tests to decide between type 1 and type 2 diabetes. I cut and pasted this in here. I have done insulin autoantibodies a couple of times. Again, these are tests that predominantly you'll see the endocrinologists do when they're trying to figure out if someone's a type 1 or a type 2. There's also a type 1.5, which we won't get into here. But at any rate, so there is testing that is available, and you might see the endocrinologist do it. So that was a quick and dirty look at diabetes. Let's talk about thyroid disease. So in a patient with thyroid disease who has, malaise, tiredness, in general just not feeling well, constipation, thinning of the hair, you're going to be thinking hypothyroid. And so the testing that you're going to do usually is the TSH. You'll still see some references to the sensitive TSH. All TSHs that are done now are the sensitive, so there's no need to order anything separate. You just order a regular TSH. The other test to think about doing is the free T4. Lots of different references. Some references say there's no need to do it. Other references do suggest it. For most of us, those are the two tests that we're going to do. Remembering that the T3 is actually the active version of the thyroid, but it's very unusual that someone have a problem with conversion from T4 to T3, so that unless you're having someone that is not really responding to treatment, there's probably not a whole lot of reason to check T3 levels. That being said, the endocrinologists seem to do it on a regular basis. There are some clinicians who do it. I'm not sure that it does any harm. I'm just not exactly sure that it adds a whole lot to the presentation for, just a basic primary care provider like me. So once you diagnose someone with a thyroid disorder, if they have hyperthyroidism, almost everybody is going to need a endocrine consult, because the big concern there is that they have a secreting tumor in their thyroid gland, and that they therefore need scans and evaluation. Again, you may get to the point where you're comfortable ordering that radionuclide scan. Most of us, if you have someone who has a substantially low TSH, high free T4, will refer people to endocrinology just because of that potential risk for thyroid cancer, period. The other possibility, of course, is low thyroid. And if you've got somebody who has malaise, fatigue, constipation, thinning hair, thinning of the lateral eyebrows, and you order a TSH, and that TSH is high, and then you order a free T4, and that free T4 is either low or low normal, then you have diagnosed hypothyroidism. Now, the majority of people with hypothyroidism have Hashimoto's thyroiditis. And so when they have Hashimoto's thyroiditis, it's an autoimmune process. You can order an anti-TPO and an anti-thyroglobulin antibody, and those will usually be elevated in that case. I guess the question is, how much does that help you? Because if you have someone who has elevated antibodies, yes, they have Hashimoto's. If they don't have elevated antibodies, you're still just going to treat them as hypothyroidism, and they have some kind of, less than autoimmune process, it appears. So in hypothyroidism, it probably doesn't help you that much. Hyperthyroidism is probably another issue, though. Some people, if they have that low TSH, they have a high free T4, they'll do thyroid antibodies. If the antibodies are elevated, then it may not be a cancer. It may just be an autoimmune process, such as Graves' disease. And then you can go ahead and just give them something to suppress their thyroid, methimazole or PTU or something like that. Again, most of these people, you're going to want to talk about more definitive treatment options like radioactive iodine or partial thyroidectomy. And again, many of us feel like this is maybe better done by the endocrinologists, but again, if you are someone who is isolated and you have someone that has an autoimmune hyperthyroidism, it's probably not essential that you send them to endocrine. Sometimes other autoimmune processes will be in the mix when you have somebody that has Hashimoto's. Patients often read about this and want to be tested for lupus or rheumatoid arthritis or various other autoimmune processes. Again, depending on what they have for symptoms, that may make perfect sense. So leaving thyroid and moving on to sort of gynecological hormones, the FSH and the LH are hormones that are secreted by women in their childbearing years, in their years when they're still having menstrual cycles. There's going to be enormous variation. They're going to go up and down depending on where they are in the cycle. The gynecologists sometimes use them to regulate cycles. But for most of us, the FSH and LH are not tests that we're going to do very often. There is use maybe of the FSH in patients who are reaching menopause to document that they actually have reached menopause. Most of the gynecologists that I know and GYN nurse practitioners don't do this routinely, but if you have someone that is really wondering, or if there's a reason to do it, patients above a certain level of FSH are considered to be menopausal. The ratio of FSH and LH used to be used a lot in PCOS as far as diagnosis, polycystic ovary syndrome. Pretty much has fallen out of favor, although you will still see some folks do it. The Rotterdam criteria really doesn't include anything in relation to that. So for most people, it's just an exercise in intellectual exercising, I guess. So the prolactin levels, prolactin is a hormone that is secreted in lactating women. If you have someone that has galactorrhea, that they're lactating, you definitely want to check their prolactin level, because you can develop a prolactinoma in the pituitary. If you have an elevated prolactin level, then obviously you're going to have to get an MRI. You should order an MRI with pituitary protocol. And then they will evaluate the pituitary and see whether or not there's any sort of a tumor that might be secreting that prolactin. There is an occasional use of prolactin in the emergency department, because if you have someone that has something that either looks like a pseudo seizure, might have been a real seizure, some clinicians will do a prolactin level. If the prolactin level is elevated, it does support the idea that it might have been more likely to have been a seizure. The latest reading I did on this seems that it's probably most related to certain type of temporal seizures, and I'm not sure that it's going to be terribly helpful in that decision, although, again, you will sometimes see it done. So polycystic ovary syndrome, when you look up PCOS, it talks about a lot of different testing. You definitely want to do thyroid testing on them. You're probably going to do a prolactin level just to make sure that there's not any sort of abnormal female hormones. Total and free testosterone levels are probably a good idea, just because if you do have elevated androgens, that is going to be supportive of the diagnosis. Mostly, however, you're going to look for androgenic symptoms like hirsutism and weight distribution issues. Other tests that are on here, you're not going to see done very often. Endocrine might do those, gynecology might do those. Again, I'm just not exactly sure how they really help you when you have somebody with PCOS. PCOS is a very common condition, and the majority of people we're just going to put on treatment and see if they get better. So, but just to let you know that lots of times when you read articles, it's going to say these 10 tests can be done. The problem is that it's really hard because I'm not sure that they add anything clinically. So just to review the Rotterdam criteria, developed in 2003, basically they say that if you've got any two of these three criteria, you have PCOS. So if you have anovulation, women that don't ovulate, usually they have sudden onset of their periods without any premenstrual symptoms. So if a woman is having, headaches, PMS type symptoms, any of those kinds of things building up, and then all of a sudden starts her period, then she's probably having an ovulatory period. If a woman doesn't have any of those things and then all of a sudden starts her period, it's much more likely that it's an anovulatory period. We talked about excess androgen activity. Those women usually will be hirsute. And we also talked about polycystic ovaries. Note full well that you do not actually need to have polycystic ovaries to have polycystic ovary syndrome if you have the other two criteria. So as I say, for the majority of women that seem to meet this criteria, have the appearance of excess androgens, being hirsute, have that sort of classic body fat distribution, we're often going to try them on some metformin. We're going to try them on some oral contraceptives. If they feel substantially better, then we're probably just going to leave them on. So parathormone testing is not something that we're going to do very often. When you do have someone that has a high calcium, and as noted in the chemistry profile talk, make sure that you do a corrected calcium based on their albumin. Make sure that it's truly high, and one that doesn't even look high. If the albumin's low, make sure you do that corrected calcium to make sure that it just doesn't appear normal but is actually high. Doing a parathyroid level definitely will be your first step. That parathyroid abnormality, if it's found, is going to probably be a endocrine referral. Oftentimes they do need to have some of their parathyroid glands removed if it is elevated, but usually we leave that to the specialist to decide. So cortisol levels are something that are awfully tempting to do when you have somebody who seems to have either a Cushingoid or sometimes even an underactive cortisol level appearance. So the problem with them, however, is they're pretty variable. So in the morning, they're usually sometimes someplace between 5 and 23, and then in the afternoon, they're usually between 3 and 16. I had a patient recently that was about 24, but she was a very anxious patient, and so that stress, that chronic stress, raised her cortisol level. How did we know that it wasn't Cushing syndrome? Well, we did a dexamethasone suppression test. So what you do is you give them 1 milligram of dexamethasone around bedtime, and then we check their levels in the morning. If they have Cushing's, their levels are going to continue to be high. It's not going to respond to dexamethasone. If they don't have Cushing's, if it's just anxiety or stress or some other artifactual reason, you'll give them the dexamethasone at bedtimes, and then their levels will be very low in the morning. This particular patient, she went down to about 7 or 8 in the morning. Another way to check cortisol production is to do a 24-hour urine, and it measures the 17-hydroxy corticosteroids, which are really the breakdown product of cortisol. So again, cortisol is up and down here and there all day long. 24-hour urine is actually going to level all that out, and you can tell whether or not someone actually has over or underactive adrenal glands. Those who ascribe to the concept of adrenal fatigue will do salivary cortisol. Adrenal fatigue is a very controversial concept. It's often used by some gynecologists, by some integrative practitioners, and by naturopaths as an explanation for chronic fatigue, for a number of different symptoms. The salivary testing is often not covered by insurance, just because the amount of research and the support for the concept is not anywhere near as strong as most of our other syndromes. There are patients, however, who really do seem to respond to treatment for adrenal fatigue. Most of the treatment for adrenal fatigue is related to vitamins and supplements. There's not really a whole lot of medications that are used, but it is somewhat controversial because some of the folks who diagnose adrenal fatigue then sell the supplements and make a lot of money doing that. Not everybody, of course, but some do. So there is concern. There's not a whole lot of research going on because, again, the usual treatment is vitamins and supplements. So obviously no drug company is going to do that research. And there's not a whole lot of funding for research other than through for-profit organizations at this point. So we're about halfway there, and I'm going to talk about late onset hypogonadism in men. It's going to go a little bit more into the issues beyond laboratory assessment, but the majority of what I'm going to talk about in the next few minutes is specifically assessment of labs. So, whether late onset hypogonadism is something that we really even should be being aggressive for is an interesting question. A lot of men do have decreased libido, erectile dysfunction, decreased muscle mass, strength, unrelated to decreased testosterone levels. There are some, however, who do have very substantial low testosterone levels, and those men do seem to benefit from a supplement. So if you have somebody that has symptoms, generally it's probably a good idea to offer them the option of having their testosterone tested. Again, there was a drug company that was making lots of money on selling testosterone supplements a few years ago, and then lots of ads on TVs telling people to get their T checked. My experience was about 1 out of 30 or 35 guys had an abnormal testosterone, but that was enough that it was making some money for the folks who were making that medication. And to be honest with you, it's also was a real benefit for the handful of men that I had who did have substantially low testosterone. If someone has osteopenia, a man does, then it probably is a good idea to check their testosterone level. Whether or not people with low T need to be treated is a really good question. Many of the ones that had it weren't being treated. So risk factors, obesity is definitely a risk factor. In people that are obese, the total testosterone is usually not a great test. You're probably going to want to get a free testosterone. The other group that's an issue for are people that are on chronic opioids. just because the opioids seem to suppress their testosterone as well. Hemochromatosis is misspelled there. I apologize for that. But all right, so generally we want to get a morning specimen for testosterone. It doesn't need to be fasting per se, but generally because of the daily changes that occur, you generally want to get it in the morning. There is not really an exact limit of exactly what's normal. Interesting article there from Wang et al., actually usually pronounced in China as Wang, and they basically went through and saw that the majority of labs in a certain geographic area were using the same machine, but the vast majority of them had different ranges for what they felt was the normal. So, in general, if somebody's above 350, they probably don't need replacement. If they're below 230, they may have benefit. In general, a lot of clinicians, including myself, find that those people that are between 200 and 300, I rarely see that they get a whole lot of symptom relief. Men that are below 200 do seem to have better energy, quality of life, but again, the men that are in that 200 to 300 range rarely see benefit, and especially men that are above 300. It is interesting because there is no real specific target level. Some clinicians, if someone starts out at 275, they figure, well, they need to have a greater increase to see the effect, so they shoot for, say, 600, just because the normal goes up to 900 or so. Most people try to get them above 400. As long as they're above 400, you're probably going to see the benefit, but again, pretty controversial. So again, actually the article that I was referring to was by Lazaro and colleagues, which is also misspelled, and that there's 17 different ranges of normal. So in general, we don't know what the normal is. So if you have someone who is between 230 and 350, it's probably worthwhile to check the free testosterone. And definitely in obese men and in men that are on opioids. So if you check their free testosterone and it's less than 65, it probably supports a trial of testosterone therapy. You can try to do other testing. When it first came out, there was a lot of concern about the SHBG levels. In fact, the SHBG levels are never necessary to do at this point, just because the lab has actually compensated for that by creating the free testosterone level. So, again, you do a total testosterone morning specimen. If that's abnormal, you can repeat it with a free testosterone. If that's also abnormal, most people will do a trial of therapy at that point. Now, the other question that you have to ask yourself is, do I need to do any other testing if that total testosterone is low? Some folks believe that you really should do LH, maybe FSH, and prolactin. Meaning that if the testicles have stopped producing androgen, then normally the brain will have started increasing the stimulating hormones, FSH and LH and prolactin, telling it to produce more. So in other words, if you have primary testicular failure, then you will have elevation of the FSH and LH. And then, as you would replace it, those should actually return to normal. The argument there is that if you have someone who has a brain issue, and then you give them testosterone, the brain hormone is just going to compensate, and they're going to end up not really raising their testosterone levels at all. there's two ways to handle that. One is to do the testing, and the other is to repeat your testosterone level in 3 months or so, and then see whether you've had any improvement. If you haven't had any improvement, then you can either refer them to a specialist, either endocrine or urology, or alternatively, you can do the laboratory testing yourself. So the normal trial of therapy is 3 to 6 months to get effect for libido and sexual functioning. Men that have borderline symptoms, you can try 3 months. They may have some placebo benefit, but as I say, if I in the men that have levels above 200, I've rarely seen any effect. You may actually see better effect from the PDE5 drugs, the Viagra, Cialis, the Vitra, and they may work better if the patient's on testosterone. They may actually have improvement in body fat, muscle mass, cardiovascular function. There is conflicting data. In general, the feeling overall is that it probably does not increase the risk of cardiovascular disease, but there does seem to be an occasional study that does seem to suggest that there is some risk. I deal with that by just telling the patient that there's some theories that it might increase that risk, and documenting that in my informed consent when I put somebody on testosterone. Again, salivary testosterone really is usually not covered by insurance, really does not have a whole lot of use in sort of mainstream practice. Some integrative folks will use it, but sort of for the run-of-the-mill folks, most of us are not going to do that. Make sure that you do a PSA and a digital rectal exam before you start testosterone treatment. You really should also do testicular exam just to make sure that they don't have dramatic testicular atrophy. Although if they did, treatment, was probably going to be a logical thing to do, but you'd want to know that. If there's any suspicion that they might have a male breast cancer, then obviously you're not going to use, male hormones. So make sure you repeat that PSA in 3 to 6 months, at a year, and then every year after that. You also should do a blood count because they can actually develop, a polycythemia kind of thing where their red blood count goes up. And obviously if their red blood count goes up, that's going to increase their risk of a clot by some. If you have somebody who has, a lot of lower urinary tract symptoms, up at night a lot, difficulty starting their stream, you're probably familiar with the LUT scale. If that LUT score is greater than 21, that's really a contraindication to testosterone treatment. You're going to want to get that addressed first with either medication or surgery. So if you've got somebody that's CRIT's already high, obviously you're not going to do that. Untreated sleep apnea is also a contraindication, and as is untreated heart failure. I think both of those are semi-intuitive, although you do need to be thinking about the fact of whether or not they have sleep apnea. Treatment goals, again, the literature usually says the total testosterone should be in the lower to mid young adult male range. Again, if we use a normal of 300, it should be, probably above 400. But as I noted, some clinicians really do try to get even higher than that. Basically, you just want to get their symptoms better, their energy level, their libido, all of the things that they were complaining about. Are there non-prescription options? DHT is not really available here in the United States, but alpha-5 reductase inhibitors like finasteride should increase DHT some. Obviously, though, that's really not going to be a treatment for low testosterone. There are patients that try to use DHEA, some of the supplements that you can get at one of the vitamin stores. To be honest with you, I have patients that want to do it, and I don't necessarily discourage them. I let them know that there's not a whole lot of evidence that it's necessarily going to be helpful, but if they want to try, that really the only downside is the cost of those medicines. And I think some of them do get some placebo effect, and to be honest with you, I've had some that have taken some of these medicines and then we've rechecked their testosterone a year later and it's been higher. Might just be coincidence, but you never know. Natural testosterone, again, you'll find people that find things online. To my knowledge, there is no testosterone that can be taken orally and not immediately metabolized into an ineffective state. The HCG is sometimes used, but not by a non-specialist. And at some point down the line, we may use other medications, but as of right now, there's not really any other options for men with hypogonadism. So this was a quick and dirty review of some of the endocrine issues. Again, the majority of these things I think are going to be treated by specialists, but these are tests that you should be basically familiar with.